Okay. Hello, everyone. I think we should probably just go ahead and start in the interest of time. So, Brian, just feel free to share your screen whenever you're ready. Thank you so much for being here and giving this talk to us. And everyone, if you could just turn on your cameras if available. Thank you.
Excellent. So thank you so much for the excellent introduction. I'm going to go ahead and, it says this will stop sharing the other person's screen. Is that okay if I go ahead and share?
That is okay with us. Thanks.
Got it. Okay. All right. Let's get this up and running. All right. So thank you so much for, providing me the opportunity to talk to this group. I, first and foremost want to say that, the organ donation process is one of those things that if you're not part of the donation process, a lot of times there's a lot of mystery to how this process works. I have been with the organization, the LiveOn NY organization for 7 years now. And prior to joining this organization, I knew 0% of what donation, how the process actually worked. So as the residents, as the treating team of these patients, our collaboration and our work together is the most important piece of the organ donation process. And without your help and collaboration, organ donation doesn't happen. So the presentation we're going to talk about today, and apologies for starting halfway through the presentation, is going to talk about the best practices for organ donation, how our teams work together to facilitate the process, and then what our relationship means and what the best practices are and things that you can do personally to affect the organ donation process. So first and foremost, I want to give everybody a little bit of an overview of who LiveOn NY is and what we do as an organization. So LiveOn NY is what's called an organ procurement organization, or an OPO for short. We are one of 58 federally designated and not-for-profit OPOs across the country with the same mission of saving lives and strengthening legacies through organ, eye, and tissue donation. So each OPO has a service area that they work with. So it's a specific group of hospitals in a specific area that we're contracted with to provide the services of coordination of organ and tissue donation. So the Mount Sinai Health System is part of our service area, along with another 86 acute care hospitals, including 11 transplant centers, which, the Mount Sinai Hospital, the main campus hospital, is one of those 11 transplant centers that we work with. Our responsibility within the healthcare field is to evaluate organs and tissue for recovery and transplant purposes. So another thing that we do is we're the ones that lead the donation conversations with families, right? So there are families that are going to have loved ones that are either near death or have already died. And the OPO, or LiveOn NY, is the one that's going to be talking to that family about organ and tissue donation. We also provide comprehensive aftercare services and support all of our donor families after their loved one has passed away and after donation has taken place. So we have a group of people that help support families emotionally for 2, 4, 5 years after the donation actually takes place. And then my department, which is hospital development, we work very closely with all areas of the hospital to develop policies and procedures around organ donation to help streamline the process. So why are we here? Why do we do what we do? Why is organ donation such an important and critical issue? Well, there are thousands of people waiting for a life-saving transplant, and they are, you could know somebody, you might know somebody who's waiting for a life-saving transplant, and each one of those people has their own story, right? And this was one of those people. So Matilda was just a couple of days old when the doctors told her parents that, she had an inoperable liver tumor and she needed a liver transplant or she would not live to see her first birthday. And that's a horrible thing for parents to have to hear. Well, luckily, somebody who was going through the worst time of their life and losing their own child said yes to organ donation. And because of that, Matilda was able to receive her liver transplant. And here on the right-hand side is her 5 years after that liver transplant, getting ready for kindergarten. And that couldn't have happened without the work of the hospital staff and LiveOn NY working together. But like I said, Matilda was just one of thousands of people. Right now in the United States, there's 106,000 people waiting for a life-saving transplant. And in fact, just in LiveOn NY service area, there's almost 8,000 of those people who are waiting. So this is a really critical issue, and that's why it's important and why I so appreciate, the platform to educate this team on the organ donation process. So what are some things that LiveOn New York is currently doing to try and combat this donor shortage, right? What are we trying to do, in the community and the other areas to decrease the number of people waiting? Well, public education and signing people up on the donor registry is critical. So public education about organ donation is, we have one of the fastest growing registries, meaning the number of people that are signed up on their driver's license to be organ donors when and if they become an eligible candidate is growing every year. And that public education is really critical. We're also working closely with lots of legislative bodies to pass beneficial legislation to support organ, eye, and tissue donation. Another thing, and I'm sure all of you are going to or know about this or familiar with this, is that medicine changes almost daily, right? There's new treatments, there's new criteria, there's a lot of changes that happen on a daily basis. And we are constantly expanding and re-examining our inclusionary criteria. So there's no upper age limit for organ donation right now. In fact, last year we had a 95-year-old liver donor, and that liver was transplanted to a 67-year-old. We've had patients that are HIV positive, Hep B positive, Hep C, and now COVID-19 is also not a contraindication for organ donation. In fact, just today, we have a patient in another major health system who has COVID-19, whose cycle threshold is, over a certain amount, right? So their virus is not replicating that much. And that patient is consented for organ donation, and they're going to donate their organs. And then we're going to treat that recipient with monoclonal antibodies and different prophylactic drugs to stop that infection from going to them. But beyond all of these things that I'm talking about, the most important piece of the donation process is our partnership together. So the way that we work together, it has the biggest and most positive influence on the organ donation rates. So where do as residents and new physicians, how do you fit into the process? So the first thing is recognition of when patients should be referred to LiveOn New York. So LiveOn New York is a third party entity, right? We're federally designated. We don't work exclusively inside the hospitals. So in order for us to be notified of potential organ and tissue donors, we need to be called by the hospital. So there's two separate criteria for referrals or calls to LiveOn New York. One of those is with mechanically vented patients that are meeting any of these clinical criteria. In absence of two or more brainstem reflexes, a Glasgow Coma scale of less than or equal to 5, or prior to any end-of-life discussion with the family. So we should be called, again, mechanically vented patients with any one of these clinical criteria being met. These patients are potential organ donors. Now, the next set of patients would be your potential tissue donors, and that would be your patients that already have a cardiac time of death. So a patient that is deceased on any unit floor in the hospital should be referred to LiveOn New York within 1 hour of that patient's time of death so that we can evaluate that patient for tissue donation. Now, within the Mount Sinai Health System, it is a nursing-based referral program. So the bedside nurses are the ones that actually make the phone calls. But as residents, especially if you're going through rotations on the critical care units, the ICUs, and the emergency department, wherever you're going to be, recognition of that referral criteria is important. And you can go to your bedside nurse and say, hey, we're going to be talking to this family about, trach and peg versus withdrawal of life support. Let's make sure we refer this patient to the OPO and make sure that call gets made. So being cognizant of these referral criteria is really critical for you guys when you head out to the units. The next thing is there's a couple really important reminders for you to remember is that, all vent-dependent patients should be called in to LiveOn New York. It doesn't matter what their past medical history is. It doesn't matter if that's a 110-year-old with HIV and active cancer. Call that patient into us, and then LiveOn New York has the responsibility of triaging that patient. It's also important that you do not mention organ donation to the families prior to LiveOn New York being involved in the process. And the reason being is that families sometimes, especially if it's brought up by a member of the healthcare team, will have a very negative first reaction to somebody mentioning organ donation, right? So if a member of the care team goes up to that, that family member, that mother, that father, that brother, that sister, and says, hey, your loved one's not going to recover. Do you want them to donate their organs? you being on the treating team, that presents a conflict of interest. So that's why LiveOn New York is a third-party entity. And I'm going to talk a little bit later in the presentation about some best practices about, how those approaches should take place and how we can work together to put ourselves in the optimal situation to approach that family about donation. It's also important that we don't withdraw or limit any type of life-sustaining treatments to these patients prior to LiveOn New York being involved and making a determination about medical suitability, because it's not only, yes, it's a CMS criteria, it's part of the New York State public health law, but when it comes down to the ethical and moral side of medicine, every family has the opportunity to know that organ donation is an option for their loved one if their loved one's a suitable candidate. So it's important that we're making early referrals, we're collaborating with LiveOn New York, and we're ensuring that we're not, actively de-escalating care on these patients if their loved ones can still have the potential to donate their loved one's organs. So here is just a little algorithm that shows you the two different types of donation that I mentioned, right? So on the left-hand side of this algorithm, you have the tissue donation side. So that's a patient who's called into LiveOn New York post-cardiac arrest or past cardiorespiratory death. The patient's going to be evaluated by one of our members of our call center. And then if the patient's a suitable candidate for tissue donation, we're going to call the family over the phone to offer them that as an option. So that's simple, straightforward process. Now, on the right-hand side of this algorithm is the solid organ donation side, which does get a little bit more involved. So these are going to be your ventilator-dependent patients with non-recoverable injuries. And those patients are going to go down one of two pathways, right? Either that patient has an irreversible loss of all brain and brainstem function, and that patient is pronounced brain dead, or the family elects to take their loved one off life-sustaining measures. And in that case, the patient can still be a potential organ donor through a slightly different pathway of donation after circulatory death, or DCD for short. Both of these scenarios can lead to a patient donating 8, even 9 organs, heart, lungs, liver, kidney, pancreas, and intestines. So obviously, if we were in a room together, this is where I'd pause to ask you the question of, what types of injuries do you think most often lead to donation happening? But in the interest of time and, saving you guys the typing energy, it used to be head trauma, right? The typical organ donor, what people think of as the most common type of organ donor is, your patient with a traumatic brain injury, somebody that was in a car accident or a slip and fall, something along those lines. And it's correct that there is a subset of patients that suffer traumatic injuries that do go on to be organ donors. But the reality is that a vast majority of the organ donors, now in 2020, 2021, and now going into 2022, are patients that just suffer some type of anoxic injury, meaning that they're patients that are usually older, usually sicker, and usually have multiple comorbidities, most of which led to that cardiac arrest. Right? So a vast majority of our organ donors are no longer the young trauma patients. They are the 45 to 70-year-old patients that have comorbidities such as diabetes and hypertension, that had a cardiac arrest in the field and sustained a long enough downtime to create an anoxic injury. So what does that mean for you all? Right. And I see that we have kind of the internal medicine group here, right? So predominantly you may be going to like the CCU or the medical ICU or, one of the floor units, right? So patients on the medical ICU, right? Sometimes it's not as easy to recognize them as a potential organ donor because they didn't have that one central event that led to their injury, right? They're not the car accident or the head traumas. They're generally sick patients that have poor health and have deteriorated over time. So as soon as you recognize that this patient's in a non-recoverable scenario and is on a mechanical ventilator, that should prompt that call to LiveOn New York so that we could evaluate that patient. So what happens after we make that referral, right? After you make that referral to LiveOn New York, what are the next steps that precede from there? So unlike tissue donation, when we have a potential organ donor, we are going to dispatch a staff member on site to evaluate that patient. So we have a team of over 60 transplant coordinators, and we have about 20 family support advocates, and they are our first responders. So if we get a call from, say, Mount Sinai Morningside for a 30-year-old patient in the medical ICU that had a devastating neurological injury and is brain dead, right? We're going to send somebody on site to evaluate that patient. We're going to be, we all have medical record access. So we have Epic access. We're going to access the patient's chart. We're going to assess medical suitability. But most importantly, we're going to work with you. So we're going to come on site. We're going to talk to the attending. We're going to talk to the resident. We're going to talk to the bedside nurse. And we're going to determine what suitability this patient has for donation. We're going to identify the legal next of kin. We're going to identify what's happening with the family. Where are they in their understanding of their loved one's prognosis? Are they hopeful? Are they talking about next steps? Are they making funeral arrangements? All of these things will dictate what our next immediate steps are. But most importantly is making sure that family is supported emotionally, receiving frequent, clear updates on their loved one's prognosis, and also that we're preserving the donation option, right? Not de-escalating any treatments prior to, our determination of suitability. Because think about this, that family is losing their loved one, right? They're in an ICU that presumably they've never been in before. And we're trying to support them in a way that allows them to make an educated decision on some really hard things. So our communication with the family has to be consistent. So here is and please, if anybody has any questions, I know I'm rambling on, just pause, raise your hand, shout out, whatever the case is. Feel free to just stop me if there's something that's not clear you have a question on. So here's another algorithm that breaks down even further the two different pathways of solid organ donation. There's brain dead organ donation on the left-hand side, and there's donation after circulatory death, or DCD, on the right-hand side. On the left-hand side, that again is your patient that has an exam that's consistent with brain death, and that is done, the brain death examination is done by an attending physician at, within the Mount Sinai Health System. Once that patient is pronounced brain dead, or once the family is really understanding of that prognosis, that's when we're going to start thinking about, okay, is it time to talk to this family? Is it the appropriate time to talk to this family about organ donation, right? And all the while, sometimes these cases happen very quickly, sometimes they don't. Sometimes, especially if the referral is timely, right? And we receive the referral, say today, for a patient that was just admitted with a devastating injury, we might not end up talking to that family for 2, 3, 4, 5 days until we get a better idea of what the prognosis is for that patient and where that family's at. Now, in the DCD scenario, which again is your right-hand side, there's a couple of key differences. The main difference is that this patient is not pronounced brain dead. Okay, so this patient is in a non-recoverable scenario. Their loved ones, their family has elected to take them off of life support. And at that time, that's when we would start to, talk to that family and offer them this option of organ donation. If the family does authorize donation, then the processes proceed fairly similar from there. The only difference would be, again, one with the brain dead pathway, that patient is pronounced brain dead, so they have a legal date and time of death prior to going to the operating room for recovery. In the DCD pathway, because this patient is not brain dead, we need an attending or a designee and a bedside nurse from the unit to come with us to the operating room to perform the extubation, provide comfort care to that patient. And then if that patient is to die within 60 minutes, then they can go on to be an organ and tissue donor. But if they don't die within that 60 minutes, they are no longer eligible to be organ donors. Now, I'm sure at some point, all of you will become acquainted with Dr. Janet Shapiro, if you haven't already. Dr. Shapiro is one of our donor champions within Mount Sinai Morningside, and at Mount Sinai West, we have Dr. Susanna Kurtz and Dr. John Liang, who are our primary kind of contacts on the ICUs. They're the ones that will help champion this process. And once you do get to the units, if you're ever presented with this type of patient and you're involved in it, you'll obviously will be on site. We'll be able to talk more about how the process works in real time. But I'm hoping that today, even though you're probably learning a million other things, that you can retain some of this information. So when you get to the units, you'll know what to expect. So why is this donation conversation such an important issue, right? It's kind of this paradox where if you ask me, if you ask 100 people in public, I'm sure almost 100% of them will say at a theoretical level that organ donation is a good thing, right? There are people waiting on the wait list. If somebody is dying and they're able to donate their organs at this level, that sounds like something that everybody would support, right? And that's what all of the national Gallup polls say. This Gallup poll from the U.S. Department of Health and Human Services, which was done in 2019, and it showed that 90% of the 10,000 adults surveyed believed that organ donation was a good thing, right? But why don't we see organ donation rates as high as 90%? And just to give you an idea, at LiveOn New York, our donation rate is 40%, meaning that 40% of the medically eligible patients that get called into LiveOn New York actually go on to be donors. So less than 50% of the patients that get called into us that are medically suitable for organ donation end up donating. And that's because of the different dynamics with family members when they're on the ICUs and the trauma that they're going through, and then other factors as well. So one of the biggest things is a family's understanding of brain death, right? It's been shown in a lot of studies that a misunderstanding about brain death leads to families not making, accurate decisions about end of life care. So in this same Gallup poll survey, they asked those 10,000 adults, is it possible for a brain dead person to recover from his or her injuries, right? And this is, again, 10,000 people just going about their normal everyday lives that are answering a survey. 47% of those people could not articulate what brain death was, meaning that they did not know that a brain dead person is brain dead, right? A brain death is death. So it's critical that, especially on the ICUs, the critical care units, that we're communicating effectively with that family about the prognosis of their loved one and being very clear about what brain death is. So I want to present to you two landmark studies that were done. For a lot of us, these seem a little outdated, but bear with me here, okay? So one study was done in 1997, the other was done in 1998, and these were both part of a large study in collaboration with the Harvard School of Public Health and the Partnership for Organ Donation to determine best practices about organ donation, right? Because again, this is such a critical issue and it has been for so long. The first study that was done was how does a family's understanding of brain death impact their decision-making about organ donation, right? So these researchers interviewed over 100 families who had been approached for organ donation. And what they did was they separated these patients or these families into two groups. The first group said yes to organ donation. The second group said no to organ donation. And they asked these people a series of questions and they studied the results of their answers. And this was the first study that demonstrated statistical significance for the relationship between understanding of brain death and a family's saying yes to donation. So what they found was that when they asked these people, is a person diagnosed as brain dead, in a coma, or dead? You see, in the group that said yes to organ donation, that a vast majority, 63% of them said, we understand that a person that is brain dead is dead, they are not in a coma or something other. But in the group that did not authorize donation, that flips. So in that group, 55% of those people were not sure whether or not brain death actually meant death or it meant coma or something else. So what that means is that if those families had been more informed about their loved one's condition, or was it, or had a better understanding of brain death, maybe their decision about organ donation would have been different. So the last question the researchers asked was incredibly telling. They said, would you still make the same choice about organ donation today? And what the researchers did was that they provided a comprehensive review of what brain death is to these families. Now, in the group that authorized donation, 94% said, I'd make that same decision today if you asked me again. In the group that said no to organ donation initially, once they had a better understanding of brain death, 34% of those people said that they might make a different decision. So that's significant, right? 34% is a large number of people. Figure one donor can save 5, 6, 7, 8, even 9 lives in some cases. That's could be 100 lives that were impacted because those families did not understand brain death. So that's why understanding of brain death and making sure that that family is very clear on their loved one's prognosis is critical, not just for medicine in general, but especially for organ donation. Now, the next study was one that assessed different variables around the family donation conversation. And please, if I'm starting to get too long-winded, just feel free to cut me off if I'm coming up on time, or wave the red flag of you're almost out of time. So this second study was done, and they actually did a meta-analysis of 707 charts. And the researchers assessed multiple variables about the organ donation approach, right? So the discussion with the family about organ donation. And what these researchers found is that there were 3 variables that proved to be statistically significant. So the 3 variables that they found, and these were out of over 20 variables that they tested, was that the setting of the conversation. So when the conversation with the family took place in a private consultation room, a private setting, that authorization rates were almost 20% higher than when they did not take place in a private consultation room. So that means we should not be having these conversations with the families in a crowded hallway, even at the bedside. I know a lot of family members may not want to leave their loved one's bedside, but it's been found that having it in a private consultation room, somewhere quiet where the family can really absorb the information, has shown to give better results. The next is a decoupled request. And what the researchers defined as decoupled was a temporal separation between the discussion of death and the first mention of organ donation. So the discussion of death, or the first notification of death, and the topic of organ donation should be separated. They didn't, even if it was just a couple of minutes, this demonstrated, again, almost a 20% difference in authorization of that family when the discussion was decoupled. So the last variable that proved to be significant was who actually talked to the family. And what the researchers found was interesting was that when the OPO and hospital staff worked together and had a collaborative discussion with that family, that the outcomes were the best. So what that means is that, we should be having these discussions with the family together as a team, rather than it being, hospital versus LiveOn New York. If we get together as a team and we talk to this family together about organ donation, outcomes are, statistically shown to be better. Another thing that's critical around the donation conversation is the timing of that conversation. When are we talking to these families about donation? I talked a little bit about this before, but it's really important that we are talking to the families at the right time. And to create consistency, at LiveOn New York, we developed 6 scenarios that trigger a donation discussion. So the first scenario is that the patient is pronounced brain dead. That is explained to the family, and the family understands that prognosis. So that absolutely is a time when we should be talking to them about organ donation. The next scenario would be if a family mentions donation. Obviously, some people are more well informed about organ tissue donation. They might bring it up to you. If a family brings up donation to you, right? So Dr. Smith, sorry, I can't see anybody's names here, are at the bedside and you're giving a great prognosis to a family, and that family member says to you, I want my loved one to donate their organs. This is what you should say. That's wonderful that you're thinking of others during this terrible time. I'm going to go call my colleagues at LiveOn New York, and I'm going to have them come speak to you. And that's it. If somebody brings up donation, it's as easy as that to transition the conversation to LiveOn New York. If a family is making decisions to limit or decelerate or withdraw therapies, anything that could jeopardize their loved one's stability, that should be a time when we, that LiveOn New York, should initiate a conversation about organ donation. Because a lot of times families make these decisions without knowing that jeopardizes their loved one's ability to donate. So I might be a family that says, I want to stop dialysis. I don't want any more medications to be administered. I want to make my loved one a DNR. And then, God forbid, that patient cardiac arrests and are no longer a suitable candidate for organ donation. That family may then say, oh, okay, so they can donate their organs now. And that's not right. So it's important that we're talking to them before those decisions are made so that we can maintain that opportunity. Next would be if a family understands the non-survivable nature of their loved one's injury. So even before brain death is pronounced, if a family is saying things like, okay, what's next? Okay, can we transition to comfort care? Can we involve palliative care? I'm going to go make funeral arrangements. All of these things means that family is accepting of that scenario, and it's time to talk to them about next steps, which organ donation is one of. Next, if donation is ever mentioned independent of LiveOn New York. Again, this is not something that should happen. Nobody on the medical team should be bringing up organ donation to the family, but there are times when it does happen, all right, whether it's by mistake, whatever the case is. If organ donation gets mentioned to the family, then LiveOn New York should come in after that to give them a full perspective on what organ donation, what the process looks like. So again, I want to reiterate, we should not be bringing up organ donation to the family, but if it does happen to come up, you can transition that conversation, and LiveOn New York should follow that up. And then the last would be any pulmonary or hemodynamic instability, right? If a patient is really unstable or on the verge of coding, and we should talk to that family about preserving the option of donation, right? We can do something, what's called a rapid recovery. So we've had scenarios where patients are unstable, their family is, considering taking them off the ventilator, and then we can actually facilitate a donation after circulatory death, a DCD, in usually 2 to 4 hours. So these are all things that, you'll dive deeper into when when and if you are on a unit that experiences a donor, but I just want you to know all the scenarios now. Now, it's important for us to know that there's a specific hierarchy of people who can authorize donation. I'm not going to go through this whole list because I'm sure this is something you'll cover at another point, but we follow the New York State Public Health Code, or the Uniform Anatomical Gift Act, which lays out the hierarchy of decision making. Now, it starts with a healthcare agent and then goes all the way down to number 10 on that list, which is any other person authorized or under obligation to dispose of the body. I know that's a mouthful. Basically, what that means is that if nobody else is taking responsibility for this person, that ultimately it could be the hospital's decision to donate that patient's organs. And that happens very rarely. Usually it happens with folks that don't have any next of kin or are undomiciled. And then it would be the hospital administration, Dr. Radbill or Dr. Breen, whether it's Morningside or Dr. West, to make that decision. Now, I've talked a lot about collaboration during this presentation, right? Collaboration is kind of like, I guess you would call it like a kind of a cheesy word, right? Like we talk about communication and collaboration, but I mean it when that's the most important part of the process. And because we're coming into a scenario that we don't know about in some cases or have very limited information about, we like to conduct a lot of huddles or care team briefs. And basically what that is it's a huddle of everybody involved in the care of that patient, including LiveOn New York, to discuss, the patient's status. What's the clinical plan? What's going on these next couple of days with this patient? Has the family been making decisions about comfort care or mentioning next steps? Where are we in all of this? And, the more we communicate or the more effectively we communicate, the better we are to have a positive outcome, or the more likely we are to have a positive outcome. So working together and making sure we're all on the same page is critical. And I encourage any one of you, if you're on a unit, you're following a patient, or you have a patient that's being followed by LiveOn New York, and you don't know what's going on with that patient, you can call our 1-800 number to get an update, or find that transplant coordinator that's on site and say, hey, listen, Brian, we're following patient in bed 6 on the MICU. I don't know what's going on. Can we just pull a quick huddle together? You can do that. I encourage you to do that so that we're all communicating effectively. Now, if everything works out, right, we talk to the family, that family says yes to organ donation, what happens from there? Well, in a lot of cases, it involves a lot of medical management, right, and testing and diagnostic testing to determine that patient's organ function. So this is something that we'll always work together to do, and we will do and initiate once a family says yes to organ donation. It involves a lot of, hormonal replacement, dialysis, recruitment of the lungs to optimize their function, and then a lot of different, basic labs and things like that. And all of this is geared towards assessing organ function or improving organ function to better our chance of transplanting that organ. And this is a quote from, one of the papers that was put out in the New England Journal of Medicine in 2004 from Dr. Wood. And Dr. Wood was an ICU physician who was a big advocate for donation. And what he said is like the care of the donor is essentially the simultaneous care of multiple recipients, right? And I've heard this before. I go to a unit and I'm talking to a physician or somebody about a brain dead patient on the unit, and they tell me, my priority is patients who are alive, right? And I've heard that. That's great. I appreciate that. But that brain dead patient, right, is essentially could save 8, 9 lives if that family says yes to organ donation. So it's important that we don't look at that one patient as a lost cause, or, that patient's, there's no way they're going to recover. Why would I treat this patient? Well, that family has the right to make a decision about donation. And 2, you're looking at one patient that could essentially save almost 10 lives, which is an incredible thing. So how do best practices affect our donation outcomes, right? So the timeliness of those referrals, making sure ventilated referrals come into LiveOn New York within 1 hour of, those clinical triggers being met, and then having a planned donation discussion. This is data from 2018 from the country's most successful OPO. So in Philadelphia, there's a OPO, just like LiveOn New York, called the Gift of Life Donor Program. And Gift of Life Donor Program in Philadelphia will average 600 to 700 organ donors a year. And they have a very similar demographic to us here, in New York. Similar, not exactly the same. But this is data from full year 2018 that showed exactly how those two best practices I talked about impacted their data. So when the referral was timely and the donation conversation with the family was planned and effective, meaning that there was no mention of donation independent of Gift of Life, there was no, pre-mention or anything like that, 68% of those patients went on to be organ donors. But if you look at when a referral was late and when it was an ineffective approach, that donation rate drops to 22%, right? So a 46% difference in those two rates when you look at these two relatively simple variables. So that's two things that we can do right now, work together to do at Mount Sinai Morningside and Mount Sinai West that could positively impact the donation process. Now, some other things that we can do to positively impact donation and create a positive culture about donation is kind of our language sensitivity, right? The language we use around organ donation. Words like recover and procure rather than harvest, right? We're not corn. We're not harvesting. That word has a lot of negative connotations to it. So we don't like you to use the word harvest. Surgical recovery, surgical procurement, deceased donation, donation after brain death, mechanical support, ventilated support rather than cadaveric donation or life support. And then LiveOn New York or the OPO and not the organ donor people. And I swear to you, I've been in a hospital before where I was going to talk to a family, and as well-meaning as it was, the doctor introduced me as the organ donation guy. All right. And listen, as endearing as that might sound, if it's just you and me having a conversation, the family was a little put off by the organ donor guy coming to talk to him. So we want to be using proper language around, the OPO and LiveOn New York and organ donation as a whole. Some other things, that's important for us all to realize is that, families will say no to donation sometimes because of myths and misconceptions about donation, right? So a lot of people think that certain religions don't support organ donation. And, of course, everyone's religion is up to their own interpretation, but every major religion supports organ donation. That includes patients that are Jewish, patients that are Muslim, patients that are Jehovah's Witness. All of these different religions do support organ donation. Patients that are organ donors can have open casket funerals. Organ donation does not cost any money to the family. In fact, doesn't cost any money to the hospital either. So LiveOn New York assumes the cost of donation from the point that that family says yes to organ donation through the actual surgical recovery. We also work very closely with the medical examiners. So patients can have a hospital or medical examiner autopsy and still be an organ donor. And then the most common thing I hear is, oh, I'm too old, I can never be a donor. I have diabetes, I can't donate. Or if I sign up to be an organ donor, they're not going to save me if I come into the ER, right? All of those are total misconceptions. Patients that are brought into the ER, if they're not medically treated, then their organs won't be functioning, right? So I'll tell you 9 times out of 10, we're advocating for more aggressive treatment of patients rather than the opposite of that. Right. So there's a lot of things that do take place between the time when we obtain authorization and when we actually schedule the OR. We are going to be finding recipients for that patient's organs. We actually find a recipient and a backup recipient for every organ that we're going to be allocating. After we allocate those organs, we then coordinate the time for the surgical recovery in the OR. Now, after the recovery takes place and lives are saved through transplantation, those donor families are part of our aftercare program, and they get follow-up letters, they get phone calls, they get different types of support groups or bereavement literature. All of this is geared towards supporting that family through the loss of their loved one. So our care for that donor family doesn't end after donation happens. It ends when they say, I don't need that anymore, which some families never do. We support families sometimes for a lifetime. And when donation happens, it's really an amazing thing. So this right here is a donor mom. Her name is Tomasa, and her son Elvis passed away when he was very young from a tragic scenario of a gang-related shooting that went rogue, right? And Elvis passed away when he was 9 years old. And because of the collaboration between LiveOn New York and the hospital that Tomasa's son was at, Tomasa was able to make the decision to donate her son Elvis's organs, and he was able to save 4 lives that day. And one of those lives was of Georgia, who's on, in the white shirt on the right-hand side of the picture. And Georgia received Elvis's heart transplant. And actually, Georgia is in her 2nd year of medical school at NYIT right now. So that one decision that Tomasa was able to make because we worked together led to all of this positive outcome. So to summarize everything, right? Again, I know you're learning a lot of things today. I certainly appreciate that. If you tuned out all of the whole presentation, which I certainly hope you didn't, remember this one slide. Timely referrals to LiveOn New York for all ventilator-dependent patients with non-survivable neurological injuries or illnesses is imperative. Making sure that that family is well supported and receiving frequent updates about their loved one's condition, having an appropriately timed, sensitive donation conversation where we decouple that conversation and we do not mention organ donation independent of LiveOn New York. And then when it is time to actually have that discussion, we work together to do it. All of those things lead to more positive outcomes through donation. So again, if you tuned me out this entire time, please remember this one slide as you go on to your units and your assignments. So that is my whole presentation. I'll unshare my screen right now and I'll open it up for questions. Questions, comments. Brian, you did a terrible job. Brian, you did a decent job. You did a great job.
So I think there was a question from Madeline earlier on. I'm not sure if it was covered or not, but Madeline was just curious as to. Oh, okay. She's saying it was answered. That's the only question I see in the chat. So thank you so much. If there are no additional questions, it seems like if there aren't in the chat or by anyone really, then thank you so much for giving this talk. It'll be recorded, uploaded, and we're gonna take, I guess, a 15-minute break